Hey guys, I can't believe that we've reached the end. This is the last lecture that you're gonna have to sit through. Thank you so much for being so willing to participate in sort of this weird online version of SI. I do really appreciate it. I've gotten many students submitting worksheets and getting attendance credit, so I'm really proud and happy that this worked out the way that it did. But this last chapter is on therapy, so we'll go over that, and then that'll be all of the material you need to know for this fourth exam and for the final. I'll have both the fourth exam review and a final review, so you should be well prepared for both of those last exams. Here are the warm-up questions. Sorry, that's kind of a long description, but it should really be able to help you tell apart the differences between all these. Okay, let's go ahead and jump into therapy. So first, how do psychotherapy and biomedical therapies differ? Psychotherapy is all about psychological techniques, so this is really just talking to people and changing the way that they think about things, the way they behave in different situations, but it does not involve medicine, whereas biomedical therapy does involve medications or medical procedures, so things like electroconvulsive therapy or like deep brain stimulation or even lobotomies. We'll talk about those a little bit later. Those are no longer practiced, but all of those types of things would fall under biomedical therapy because there are medications or procedures. Whereas psychotherapy is sort of your classic therapy where someone's just going to come in and sort of talk about their problems, and you'll give them advice and inform them of sort of different things that they should be doing or different ways to deal with the crises that they're experiencing. And then the eclectic approach is an approach to psychotherapy that uses techniques from various forms of therapy. So really, all you need to know is that eclectic means that you're deriving your ideas or whatever from a diverse range of sources. So you're collecting information and research from all sorts of different sources to try to put together the best approach to therapy that you can. So the eclectic approach is pretty common. That's what we expect people to be taking, the type of approach we expect people to be taking. Good therapists, at least. Okay, I know we already talked about psychoanalysis and psychodynamic earlier, but now it's in reference to therapy in particular. So psychoanalysis was, of course, Freud's technique. We used free association, and then we'll talk about resistance and interpretation and transference as well. So the goals of psychoanalysis are to become less anxious. Remember, it's all about relieving anxiety. Those defense mechanisms, those psychosexual stage fixations, it's all about relieving anxiety. And we do that by releasing these unconscious tensions that we have between our id ego and superego, and these inner conflicts that we have that are keeping us from moving forward, that are getting us stuck or fixated at some kind of stage. To bring repressed feelings into conscious awareness is, of course, the other goal as well. Some techniques. The main technique is free association, which we talked about earlier. That's when you just sit down and the therapist, Freud, would say a word and you just say the first thing that comes to mind. And that was supposed to uncover information about resistance. So I actually kind of really hate the definition that they gave you for resistance in the textbook. So kind of, ignore that. But really what he's referring to with resistance is that you get to a certain point in therapy and you want to resist the therapy. So you try to leave therapy. That's what resistance is really talking about, is leaving therapy. And it's kind of due to this underlying issue that you're trying to repress this anxiety-laden material from your consciousness. But at the end of the day, when we're talking about resistance, we're talking about someone who has been getting psychoanalytic therapy, and then they say, I don't want to be here anymore. And Freud says, well, you're just resisting treatment, but that just means that we're close to a breakthrough. So you need to stay. And we're about to make some really good progress. And that's how he kept people coming back. Interpretation. Okay, what I want you to write down for this is that interpretation is what made psychoanalysis unreliable. Interpretation is what made psychoanalysis unreliable. When we talk about reliability in psychology, it's all about consistency. So, when we talked about the pseudoscience of phrenology, studying those bumps on people's heads, we talked about how it was unreliable because if you went to different phrenologists, they would tell you different things. And Mark Twain, notably, went to 2 different phrenologists, one of which told him he had the largest bump for humor that he'd ever seen, and the other phrenologist said that he had no sense of humor at all. So there's no consistency in these answers, which makes them unreliable. And so with interpretation, this is just the psychoanalyst interpreting what your dreams mean, what your resistances mean, and other, behaviors and events in order to promote insight for you. But the thing is, interpretation is not consistent between psychoanalysts. And so you go to one and they would tell you that, your dream that you were riding a horse in the field meant that you were sexually repressed, and you go to a different therapist and they say that dream means that you're suicidal, right? There was just no consistency. So interpretation is what made psychoanalysis unreliable. Okay, transference is when you take these negative emotions that you have about other people and you put them on your therapist. So really, transference is projection, but only on your therapist. So if you're angry with your father and you're making some progress in psychoanalytic therapy, then Freud's going to predict that you're going to take out that anger that you have towards your father on your therapist. So you're projecting those negative emotions that you have, anger or whatever, onto the therapist, not on anyone else, just onto the therapist. And that's what transference is really speaking to. And then we talked about the differences between psychodynamic and psychoanalysis, but psychodynamic therapy is all about the unconscious and childhood experiences, but it does not include any of Freud's id-ego, superego, resistance interpretation, transference, psychosexual stages, dream interpretation. None of that stuff that we really couldn't verify from Freud is included in psychodynamic. We're using more scientific methods in psychodynamic. Okay. So when we talked about insight in chapter 9, we were talking about how insight is kind of that aha moment when you realize something that you didn't know before. So insight therapies are therapies that aim to sort of bring you into this awareness of something about yourself that you didn't know before. So they aim to improve psychological functioning by increasing your awareness of your underlying motives and defenses. So both psychodynamic and humanistic therapies are considered insight therapies, but they're very different from one another, almost opposite, really. But know that both of those are considered insight therapies. And now let's talk about the differences. So how does humanistic therapy differ from psychodynamic therapy? Humanistic therapists try to boost people's self-fulfillment by helping them grow in self-awareness and self-acceptance. The goal is always growth. Promoting this growth, not curing illness, is the focus of humanistic therapy. They actually call people clients rather than patients in humanistic therapy. So humanistic therapists do not believe that when you come into therapy, there's something wrong with you. But psychodynamic therapists say there is something wrong with you and you need my help to figure out how to combat that, essentially. But humanistic therapists say, no, there's nothing wrong with you, but you might need some support to be able to self-actualize, to grow, to reach your fullest potential and become the best that you can be. The path to growth is taking immediate responsibility for your feelings and actions, whereas in psychodynamic therapy, they're focusing on uncovering these hidden, motives and feelings that you have. So humanistic therapy is a much more conscious thing, whereas psychodynamic is more unconscious. That's the next point. Wow, I almost have these PowerPoint slides memorized. So yes, in humanistic therapy, conscious thoughts are way more important than the unconscious, whereas psychodynamic says the unconscious is more important. The present and the future are more important than the past in humanistic therapies. But the past is what we always focus on in psychodynamic therapies because we're talking about childhood experiences, right? So therapy focuses on exploring feelings as they occur. So as you feel something, let's explore it, let's deal with it, let's combat it. Instead of trying to achieve insights back into your childhood origins. So, like I said, these are both insight therapies. For humanistic therapy, they want you to get insight into your present and your future. But psychodynamic therapies want to give you insight into your past, your childhood experiences. Okay. And then client-centered therapy was developed by Carl Rogers, and this uses active listening with that, acceptance, genuineness, empathetic environment to try to facilitate clients' growth. And here's what I want you to write down about active listening. The key component of active listening is rephrasing what the client said to check for understanding. The key component of active listening is rephrasing what the client said to check for understanding. So the technique of active listening is actually something that we talk about a lot in interpersonal relationship psychology, like relationships between couples and friends and things like that. And so when you're practicing active listening, what you're supposed to be doing is you allow one person to talk and you do not interrupt, you do not disagree, you do not, even if they say something that you think is totally off base, you just sit there and listen. That's step one, just listen. And then the second step is still, you're not releasing or exposing any of your own thoughts or feelings yet. The second step is just to rephrase and repeat back to the person what they just said to you. And that's just to make sure that you're actually taking away the correct things from what they said and you're interpreting what they've said correctly. Because if you're not, then they should stop you and say, oh no, that's not quite what I meant. This is what I meant. And that's how you really avoid a lot of conflict based on miscommunication. So then the third step would be now you get to respond. So first, just listen, no talking. Then you rephrase it back to check for understanding. And then you're allowed to share your side while the other person stays silent. And then they're supposed to rephrase back to you what you just said to check for understanding. And then they can reply. And it just goes on like this until you feel that you've reached resolution in an argument. And then that unconditional positive regard we talked about before, and that's just that caring, accepting, non-judgmental attitude. No matter what your patient is telling you, you are supposed to be caring, accepting, and non-judgmental. Even if they just came in and told you that they smothered their baby, right? Or that they're a serial killer. It doesn't matter. You're always supposed to respond, oh, it's okay. It doesn't matter what you did in your past. It's all about how we move forward and how we grow from that. That's really what humanistic therapy is focusing on, which is why it gets the criticism that it's too naive and it doesn't really focus on deeper issues within people or understand that people can just be inherently evil. Okay, the goal of behavior therapy is to get rid of bad behaviors. I don't really know why the goal of behavior therapy isn't also to instill good behaviors, but know that when we're talking about the goal of behavior therapy, it's all about getting rid of bad behaviors. And it's kind of surprising, actually, what sorts of things are classified as behavioral disorders, like bedwetting is one of them, which is funny because to me, that feels like something that a child doesn't really choose to do. Normally, bedwetting happens in their sleep. But in fact, it is an issue that behavior therapy can treat, even though it is not something that's intentional. So bedwetting is an example. Nail biting is another example. Things like that. Any actual behavior. Remember, behavior is something observable that other people can watch you do. We're just trying to eliminate those unwanted behaviors. That's the goal. Classical conditioning techniques. So counter conditioning is, this definition is worded kind of funny, but you're trying to get new responses to stimuli that are triggering unwanted behaviors. So what does that mean? Let's use an example of a dog. So every time I turn on my hair dryer, the dog goes ballistic, right? Just starts running around the house, knocking everything over, barking real loud. It's real bothersome, right? So even though the hair dryer is not going to hurt them, it's triggering an unwanted behavior. It's triggering a behavior of chaos, right? And so what you're going to do with counter conditioning is you're actually going to reassociate that stimulus, the hair dryer, with a different response. So what you're going to do is, take out the hair dryer and just show it to the dog, right? Just hold it in front of the dog. And if the dog calms down, or as soon as the dog calms down, you reward it with a treat. So now we're reassociating that hair dryer with a treat instead of with a scary noise or something like that. And so once the dog can be around the hair dryer without going crazy, we keep rewarding it with a treat, and then we move on. So next time, now we're gonna actually plug the hair dryer into the wall, right? And if the dog calms down, then we give it treats. And then we're gonna just turn on the hair dryer on the lowest setting that we can. And as soon as the dog can calm down, give it treats, right? And so you just keep doing this until you're able to actually use your hair dryer and your dog no longer associates it with something scary. It's actually gonna associate it with something pleasant, getting a treat. So that's counter conditioning, is when you have a bad response to a neutral stimuli and you want to turn that into a positive response, or even just no response at all. Even if the dog just doesn't do anything, they just sit there, that's perfect. We just don't want that bad behavior of barking and running around and making everything crash to the floor. Exposure therapies are all for anxiety and mostly for phobias. Phobias is specific things. And so exposure therapies, much like the word says, you're going to expose the person to the thing that they're afraid of. And we usually do this through something called systematic desensitization. And this is sort of, a lot of these things kind of overlap a little bit. Like when I was giving the example about the hairdryer and the dog, that's a little bit of systematic desensitization. But systematic desensitization is where you expose the person to what they're afraid of in gradual, tiny steps. So let's say that someone's afraid of a spider. With systematic desensitization, you would have them look at a picture of a spider, and they're gonna have to keep doing that until they no longer feel anxiety looking at a picture of a spider. And then you can move on to the next step, which is to bring them into a room that has a glass divider, and there's a spider on one side of the glass and you're on the other side of the glass. Can't get to you, can't hurt you. And we wait until the person is able to do that over and over without feeling anxious. And then the next step would be, let's put a spider inside of a box on a table right in front of you. So it's, within arm's reach, but it's still within a box. And then once you lower your anxiety, move on to the next step. So after that, we take the spider out and we make it crawl on the table, but it still can't touch you. Once you're good with that, now we have you actually touch the spider. Once you're okay with that, we let the spider crawl on your body, for example. So that's systematic desensitization, is just slowly getting someone to the point of comfortability with the thing that they were afraid of. If someone's afraid of swimming, the prescription, if it's systematic desensitization that you're using, would be for the next week, I want you, every time you pass by the pool, to just dip your toe in it. And then for a week after that, I want you to just put only your legs in, just to hang your legs over the side into the water. And then after that, I want you to go in the water with floaties on your arms. And then after that, take off the floaties and just stand in the water. And then after that, I want you to try to swim halfway across the pool. And then after that, swim the whole way, right? It's like this, just systematically desensitizing a person to the thing that they originally feared, so that they no longer have a fear after this is over. And then virtual reality exposure therapy is just a way that we found to do systematic desensitization with things that we can't really put people in real life examples of. So if they have a fear of flying, it's not really practical for a therapist to book a bunch of different flights for a person so that they can go systematically desensitize themselves by flying on airplanes. So instead, we would do something like virtual reality exposure therapy, where we simulate a plane flight, and that's how we expose them to the thing that they fear. Aversive conditioning is going to associate something unpleasant with your unwanted behavior. So this is like when children are biting their nails, and so you put that nasty tasting nail polish over their nails so that every time they bite down on their nails, they get that unpleasant, gross taste, right? So now they're associating a gross taste, with the behavior of biting their nails so that they stop biting their nails because they know it's going to taste bad. Another example is sometimes with alcoholics, what we do is actually put a nausea triggering fluid inside of people's bottles of alcohol, and then that way every single time they drink they get nauseous and they start to associate nausea with drinking, and then they stop drinking. So that's aversive conditioning, is you actually pair the behavior with something bad, something unpleasant. Whereas counter conditioning is reassociating something that someone's scared of with a good thing. So counter conditioning and aversive conditioning are pretty much opposites. With counter conditioning, we're wanting to take the thing that they fear and associate it with something good, positive, that they like. Whereas aversive conditioning is we want to take this bad behavior that they're doing and associate it with something unpleasant so that they stop doing that behavior. Okay. And then operant conditioning, remember that this is kind of all about punishment and reward. A token economy is a procedure where people earn a token because they've exhibited some kind of good behavior, and then they can exchange those tokens for privileges or treats. So the most practical example I can think of a token economy would be AA meetings. Once you go to Alcoholics Anonymous for a certain number of days or weeks or months, you get these little chips or tokens that you can trade in for various privileges or prizes or treats, something like that usually. Or just to hold on to in some programs. They just let you hold on to them and maybe put them up in your house or something to remind you of the progress that you've made. But there are two concerns from people who criticize behavior modification in regards to a token economy. So number one, they're asking, how durable are the behaviors? So once we stop giving people those rewards, once we stop giving them the tokens, are they going to continue to do the good behaviors? Once people get out of AA and they're no longer being rewarded for not drinking, are they going to continue not to drink even though they're not being rewarded, or are they going to revert back to that bad behavior of drinking again? And the second question is it right for one human to control another's behavior? And you know, when it's in a therapy context, you're doing it for the benefit of the person. So it's fine ethically in that regard. But if you're actually rewarding people for doing bad things, that's kind of how you build psychopaths, right? So it's definitely not right for humans to control others' behavior unless it's in a scientifically valid therapeutic context. Cognitive therapies are going to want to change the way that you think. Remember that cognition has everything to do with your mental processes, the way that you think about and perceive things in the world. And so cognitive therapy needs to change the way that you are thinking about things. And so an example would be thought catastrophization. That's a big word, but thought catastrophization is when something relatively minor happens in someone's life and they just go absolutely down the rabbit hole thinking of all the bad things that could possibly happen as a result of this. So let's say that a person gets a bad grade on an exam, they get a bad grade on one exam, and they're in therapy and they're like, I can't believe that I scored so poorly on this exam. This means that I'm not going to pass the class, and if I don't pass the class, then I'm not going to graduate. If I don't graduate, then I can't get a job, and if I don't get a job, then I'm not going to have a family, I'm not going to have kids, I'm not going to be able to support anyone, not even myself, you know? And it all kind of comes from a place of anxiety, usually. But thought catastrophization is one of the main issues of cognitive therapy, and it's the therapist's job to stop you in your tracks and say, okay, let's think about whether or not these connections that you're making are logical or not. Is it true that if you failed this one test that you're going to fail the whole class? Not necessarily. you could do better on the rest of the tests. You could go in, you could get tutoring, you could talk to the teacher. There's things that you could do to stop that from being the next step, you know. And as you kind of go down that list of all the things, you sort of reveal to the person why it's a little bit irrational that they're thinking the way that they are, and you're supposed to give them alternative means of dealing with these issues instead of just thinking about how much worse it could possibly get. So cognitive therapies are to reveal your beliefs, so to actually make you say out loud what your concerns are so that you can hear it back and actually see if you sound crazy to yourself or not, right? So to reveal beliefs, to test those beliefs. So there's that word, decatastrophizing their thinking. So you're uncatastrophizing, you're stopping them in their tracks, and so you're testing those beliefs and saying, well, okay, so you believe that failing this test means you're going to fail the class, but is that really true? Because you could do A, B, C, D, or E, and you might not fail the class. And then the last step is to change those beliefs. So as you're testing those beliefs, the change is sort of supposed to be happening at the same time. Okay. And then cognitive behavioral therapy, this is the most popular and really most widely successful therapy that we have available for people. So if cognitive therapy is to change the way that you think, and behavioral therapy is to get rid of bad behaviors, cognitive behavioral therapy is to both change the way that you think and change the way that you act. So change the way that you think while also eliminating bad behaviors. So it's just a combination of the both of those types of therapy. So we want to change these self-defeating thought patterns, and we also want to change the way that people actually behave in their life. And it's usually that those behaviors are a response to their cognition. And so by fixing the cognition, sometimes you also fix the behavior. Group therapy is, well, therapy conducted in groups instead of with individuals. But the benefits of group therapy are that it saves therapists both time and clients money. It saves therapists time and clients money. So because the therapist can have more than one client at once, that saves their time because they can spend 1 hour and treat, 6 or 7 people instead of just one person in individual therapy. And then as far as clients' money, usually therapists are charging an hourly rate, and that's a pretty flat rate. And so when you have 6 or 7 people in a group all paying for 1 hour, that cost gets divided up among the people so that everyone is actually paying a little less, but the therapist is still making their hourly wage. It's just that it's coming from 6 or 7 people instead of just one. But it's often no less effective than individual therapy, which is important. There's no reason really not to do group therapy as opposed to individual. It offers a social laboratory for exploring social behaviors and developing social skills. So there's actually a program called Toastmasters for people who have a really hard time public speaking. And so that program is group therapy in a sense that it's exposure therapy too, where they want you to interact with one another and practice public speaking with other people who also have a fear of public speaking. So it's kind of a safe space for people to be able to practice these new techniques and behaviors that they're learning without really feeling embarrassed because all of the other people in the group are experiencing the same difficulties or troubles that they have. And then it enables people to see that other people share the same problems that they do. You're not alone. It's not just you. And then it provides feedback as the clients try out those new ways of behaving. So with like Toastmasters, as people are practicing giving, speeches, public speaking, then they get feedback from the other clients as they do it. And they can incorporate those opinions into their next trial, their next attempt at that behavior. And then family therapy is just group therapy, but for a family unit, right? So it treats people in the context of their family system and figures out what the family dynamics are that are causing there to be contention or issues between different members of the family. It's just a type of group therapy that obviously focuses on a family unit. Okay, second half. So the main overarching question here is psychotherapy effective, right? And so we're going to kind of talk about some criticisms for why it might not be effective, or maybe not quite as effective as we think it is. But we're also going to talk about the studies that say that it is pretty effective. So first of all, clients' perceptions can be an issue. So critics say, people often enter therapy in crisis. So when you come to therapy, something bad has just happened and you're trying to deal with it. You're in crisis right now. And we all know that no matter what your issue is, with time, things always improve, or almost always improve, right? And so when people enter therapy in crisis, whether the therapist is doing a good job or not, with time, the person will improve. That's just how it works. Clients believe that the treatment will be effective, so that's kind of like the placebo effect. If you think it'll work, you can kind of build a self-fulfilling prophecy to make it work a little bit. And clients generally speak kindly of their therapists. Why? Because their therapists are there to help them, right? It's not like you go into therapy thinking your therapist isn't going to be nice to you, right? And so clients are going to speak generally kindly of their therapists because they know that the therapist is there to try to help them. Even if they don't think the therapist is doing a very good job of helping them, they're going to speak kindly of their therapist most of the time because they think that at least their therapist is well-intentioned. They mean to help me, even if they can't. Clients also want to believe that therapy was worth the effort. And this kind of comes down to cognitive dissonance. I think that's chapter 13. Cognitive dissonance. So remember that is when your attitudes and your actions do not match up. And so instead you change your attitudes because it's much harder to change actions. And so if you want to believe that the therapy was worth the effort, that's usually due to cognitive dissonance. So we maybe didn't think that therapy was going to work, but you did the physical action of going to see the therapist every single week. So even though your thoughts and your actions may be dissonant right now, you don't think that it's working, but you keep doing the action of going, then you sort of convince yourself to believe that it is working just simply because you keep doing it. Why would I keep going if it wasn't working? I mean, it must be. I keep coming back, right? Clinicians' perceptions. So clinicians often think that they actually have more success stories than they really might. This is usually because when people come into therapy, they emphasize how unhappy and stuck and in trouble they are. But to justify leaving therapy, they emphasize how much better they're doing. So even if a client is actually leaving because this clinician isn't working and they want to try someone else, they usually just say, oh, I'm doing so much better. I don't think I need to come back anymore. Thanks so much. And then they go and they try someone new. But of course, the old therapist doesn't often know that they're trying out someone new. So they just think, oh, another success story on the books, right? But outcome research kind of goes in the opposite direction. So meta-analysis is where, this is kind of like the eclectic approach, where we're collecting a bunch of different information from different research studies, and then we run a statistical analysis on the overall outcomes. So we use randomized clinical trials where we randomly assign people on a waiting list to either getting therapy or not having therapy. So there's your experimental versus control groups. And meta-analysis showed that the average therapy client ends up better off than 80% of people who were untreated. And those who are not undergoing therapy often improve. Like I said, with time, people improve. But those undergoing therapy are more likely to improve and to improve more quickly and with less risk of relapse. Relapse is falling back into that pattern, that old pattern of bad behaviors. And so people who are in therapy are more likely to improve quickly and to not revert back to those bad thoughts or behaviors that they were having before. But the thing is, different kinds of therapies have been all about equally successful on the whole, but certain kinds of therapy do a better job at targeting particular problems compared to other types of therapy. So cognitive and cognitive behavioral therapies are best for treating anxiety, PTSD, insomnia, and depression. They have much more success at treating those things than psychodynamic or humanistic therapies have. Behavioral conditioning therapies treat specific behavior problems, like I said, bedwetting, phobias, compulsions. Remember, we talked about OCD in chapter 15. Obsessions are repetitive thoughts. Compulsions are repetitive behaviors, right? So that's why we use behavioral conditioning therapies, to change those bad behaviors, the unwanted behaviors. Marital problems and sexual dysfunctions are also considered behavioral issues. Psychodynamic therapy is best for depression and anxiety. And then non-directive or client-centered counseling, which is humanistic therapy, is only really good for mild to moderate depression, not even the severe stuff. So overall, it's kind of funny actually, because most therapists these days are humanistic therapists, and honestly, that's because that's the easiest license to get. But that is the most common therapy, and it's really frequent these days that I see people who have tried therapy and they're like, that does not work, I am not going to go back, I was wasting my money. And that's really just because the humanistic therapist is not there to tell you what to do. So if you're going into therapy with a humanistic therapist and you're expecting them to be like, this is your problem and this is how you need to fix it, they're never going to do that. The way that humanistic therapists are trained is to guide you into telling them what your problem is and what you should be doing to fix it. So a lot of the time, people get disappointed with the therapy that they receive because they actually aren't seeking out the right type of therapy for the issue that they're dealing with. So that's kind of encouraging, if you have friends or family or even yourself. If anyone's dealing with any of these specific issues, try a different kind of therapy, because humanistic or client-centered counseling really isn't all that effective when it comes down to it. So, psychology's civil war. There are 3 camps here. The first one is research psychologists who say we've got to use the scientific method and we've got to figure out what are well-defined and validated therapies for different disorders. So it's a scientific approach. We're looking at the data and the outcome research. Non-scientist therapists think that their practice is more of an art than a science. And so they say, people are too complex and psychotherapy is too intuitive to describe in a manual or test in an experiment. I just need to sit down with them one-on-one and, feel out who they are as a person, kind of a thing. You can imagine that doesn't have very high success rates because it's not based in data and valid, reliable research. But kind of the happy medium here is science-oriented clinicians. And so they call for evidence-based practice, so using that scientific method and outcome research and all of that, which is endorsed by the APA. And then after rigorous evaluation, clinicians are going to apply therapies suited to their own skills and their patients' unique situations. So they are going to appreciate the uniqueness of the person that they're treating. Not every single person is going to respond to treatment the same. And so first we look at the outcome research, what are the most effective options? And then once we have that list of options, we try to figure out what's going to be best for that individual human being. And that's really kind of the best of these 3. So science-oriented clinicians would be like ranked number 1. This is the best way to do it. And then research psychologists would be number 2. And then those non-science therapists way down at the bottom. Okay. So I am movement desensitization and reprocessing. This is such a funny thing. So what the therapist does in EMDR is have the person, the client, imagine something traumatic that has happened to them, or even just a traumatic hypothetical, while the therapist waves their finger back and forth in front of their eyes. And they're supposed to follow the finger with their eyes back and forth while they're thinking about this traumatic thing that happened. And this is supposed to help them unlock and reprocess these repressed memories. But we really don't see much success in this. Some evidence does suggest that there are some benefits for trauma survivors, but why is that? Well, it's mostly because those eye movements are going to relax or distract patients, and that will allow memory-associated emotions to go away. So you're actually just calming them down by distracting them with the movement. EMDR does work better than nothing, but they suspect that what's actually therapeutic is the combination of exposure therapy and placebo effect. So remember, exposure therapy is exposing someone to the thing that they fear or to the thing that causes them anxiety. And so by having the person envision the traumatic thing that happened to them or a traumatic hypothetical, you're exposing them to the thing that makes them anxious or fearful, right? So by exposing them to that thing in a calm environment where nothing's going to hurt them, and you're also distracting them with the eye movements, that's kind of why you can kind of see some benefits for some people sometimes. But again, it could also be placebo effect. People think it's going to work, and so they believe that it did. But what I want you to write down for this is that EMDR is a pseudoscience, and you spell that P-S-E-U-D-O, science, a pseudoscience, just like phrenology. And what a pseudoscience means is it's trying to be scientific, but it's failing to be scientific. So it claims to be a science, but it doesn't follow the scientific method. Okay, and then the other alternative therapy that we talk about in this chapter is light exposure therapy. And this was developed to counteract lethargy, particularly in the dark winter months. And so the National Institute of Mental Health researchers in the 80s had an idea to give people a timed daily dose of intense light. So people with seasonal affective disorder, and that's just depression that hits during the usually darker, colder months of the year, so kind of winter time. So we use people with seasonal affective disorder for this experiment, where the experimental group got 90 minutes of bright light, and the control group was just exposed to this hissing negative ion generator. It's a placebo, and so both of them had like coverings over their eyes, and so they couldn't actually tell if there was light around them or not. And so one group got actually the bright light, and then the other people just got a sound that made them think that something was on. And that was the control group, the placebo. 61% of people exposed to light in the morning greatly improved, and 50% of those exposed to light in the evening as well. 32% of those exposed to the placebo, though, also saw great improvement too. So about half of the variation in this 61% of people exposed to light in the morning and 50% exposed to light in the evening could be due to a placebo effect. It is controversial, but some studies have shown that light exposure therapy is as effective as antidepressants for some patients. It's not going to be this way for everybody, but for some people that is actually an effective therapy, we found. Could just be placebo effect again, but you know, it's had more success than EMDR, so that's notable. Okay. So 3 basic benefits in all psychotherapies. It offers hope for people who feel helpless or demoralized. It offers a new perspective, the therapist's perspective, really. And it offers an empathetic, trusting, caring relationship where you can rely on that therapist and not be afraid that they're going to abandon you or become angry at you or something like that. And that's what we call the therapeutic alliance. It's just a bond of trust and understanding between a therapist and a client who work together constructively to overcome whatever the client is dealing with that they need help with. How do culture and values influence the therapist-client relationship? Issues typically arise when a therapist from one culture interacts with a client from a different culture. So if you have a therapist from a collectivist society and a client from an individualist society, or vice versa, you can run into issues, mostly because your fundamental values and the way that you view the world is different, right? So collectivist people are going to be all about, it's not about me, it's about everyone else. I need to just do what I need to do to be harmonious with everyone else, to facilitate social harmony and peace, you know, whereas someone from an individualist society is like, how can I do better for myself? And we aren't really considering other people as much, usually. Culture also influences who will actually seek therapy in the first place. So people who come from typically Southern cultures of honor prize being strong and tough, and they think that seeking mental health care is an admission of weakness. When should we seek mental professionals' help? If you feel hopeless, if you have deep and lasting depression, self-destructive behavior, substance abuse, disruptive fears, sudden mood shifts, thoughts of suicide, rituals. So that's like the obsessive compulsive disorder right there. So compulsivity, rituals, sexual difficulties, or hearing voices or seeing things that others don't experience. Definitely seek treatment for that. What should a person look for when selecting a psychotherapist? People don't really realize that you can shop around for a therapist, and not only that you can, but you should. You should look for, and this is kind of goes back to what I was saying earlier about how different therapies are more effective at targeting different issues. And so you want to shop around for the therapist that's going to be the most beneficial for you. So you want to compare and evaluate multiple approaches, ask the therapist questions. The first appointment that you have with a therapist should be a consultation where they're not just feeling you out, but you're asking them questions too. It's best to find someone who shares your core values and culture. The emotional bond between a therapist and client is maybe the most important factor in whether or not therapy is going to be effective. If you don't feel trusting and close to your therapist, then you're likely not going to respond to treatment as well. Drug therapies. So psychopharmacology just studies the effects of drugs on mind and behavior. So psychopharmacology, it's that branch of psychology that develops drugs to treat psychological disorders. In double-blind studies, several types of drugs effectively treat psychological disorders, so they work. Antipsychotic drugs, so anytime you see that word psychotic, that means that we are talking about experiencing things that other people do not experience, like hallucinations, disorganized thoughts, delusions, stuff like that. So antipsychotic drugs are for psychotic disorders, which the only one we talk about in this chapter is schizophrenia. So anytime you see antipsychotic drug, it's gonna be talking about schizophrenia, just in reference to your textbook and the information that they give you. There are other psychotic disorders, but we don't talk about them in intro. They're especially effective at calming hallucinations and delusions and dampening responses to irrelevant stimuli. So these are all positive symptoms. But what antipsychotic drugs are bad at treating is negative symptoms. So remember, that's the apathy or withdrawal. So positive symptoms, again, are things that you have that are additional, that other people do not experience, like hallucinations or delusions. And negative symptoms are symptoms where you lack something normal that most other people have. So apathy, having no emotion, that's not normal. It's normal for people to have emotions. It's abnormal to have an absence of emotion, and it's that absence that makes it a negative symptom. But nonetheless, antipsychotic drugs are great at treating positive symptoms, not so good at treating negative symptoms. Anti-anxiety drugs are for, wow, no way, anxiety. And the most important thing to know about anti-anxiety drugs is that they depress your central nervous system, which is your brain and your brainstem, right? We talked about CNS and the PNS way back in, I think it was chapter 2 or 3. But yeah, it depresses your central nervous system, so your brain and brainstem activity. And this can help to extinguish learned fears and relieve symptoms of PTSD and OCD. And then antidepressant drugs are mostly used to treat depression, but they can be used to treat some anxiety disorders, OCD and PTSD, but it just depends on what is triggering the anxiety, OCD, or PTSD that determines whether you should take an antidepressant or an anti-anxiety. But that is so detailed, and the textbook really doesn't even go into it, so you don't need to know those differences. It'll be made clear in the question. And so antidepressant drugs are going to work by increasing the availability of neurotransmitters, usually norepinephrine, serotonin, sometimes dopamine, that elevate arousal and mood. And when a person is experiencing depression or anxiety, those neurotransmitters are scarce. So this is basically an agonist, right? We're increasing the effect of the neurotransmitters because there isn't enough of an effect on its own. And most antidepressant drugs are SSRIs, remember, selective serotonin reuptake inhibitors. Reuptake, we talked about this also in, I think, chapter 2. Reuptake is when there's excess neurotransmitter that doesn't bind and process, and so it just gets sucked back up by the brain, and it's not used for anything. It just gets sucked back up, and then the next time that neuron fires, maybe it gets released again. So if we are inhibiting inhibiting reuptake, that's actually causing more serotonin molecules to bind and to cause their effect because they're no longer being reabsorbed into the brain and inactivated. So anytime you see SSRI, selective serotonin reuptake inhibitor, that is an agonist. It increases the action of serotonin because what it's inhibiting is reuptake, reabsorption. It's not inhibiting the activity of serotonin. It's in fact increasing the activity of serotonin. And we've got some brain stimulation treatments. So electroconvulsive therapy is a biomedical therapy. So remember, biomedical means either we're using drugs or a medical procedure. In this case, it's a medical procedure. For severely depressed patients, where you run a brief electric current through the brain of someone who's anesthetized, meaning that they're unconscious, they're under anesthesia. And it used to be called, it's still called electroconvulsive therapy, but it's no longer convulsive, meaning that the person's body doesn't convulse or move, I guess, while this is happening, because they're given a general anesthetic as well as a muscle relaxant. So that's what prevents those bodily convulsions, because the muscles are relaxed, and so they're not gonna all of a sudden like shoot up, right? A psychiatrist delivers a brief pulse of electrical current, which triggers a 30 or 60-second seizure. That sounds dangerous, but it actually, there's some evidence to show that seizures sort of reset your brain pathways. So that's kind of how it works. And then when the patient awakens, they really don't remember anything about the treatment or the prep. So it's not something that is fear-inducing for people, or that they look back on and they have bad memories of it. They really just don't remember it at all. ECT can effectively treat severe depression, especially in patients who don't respond to drug therapy. So in patients who try an antidepressant and the antidepressant doesn't work, ECT is a really good option. And I also want you to write down that ECT is the most effective brain stimulation treatment for depression. Electroconvulsive therapy, ECT, is the most effective brain stimulation treatment for depression. Some research indicates that it stimulates neurogenesis, new synaptic connections in the hippocampus and amygdala. And then some other neurostimulation therapies, you don't have to know these very well, but TDCS is a weak current to the scalp that produces a tiny brain seizure, whereas RTMS is repeated pulses of magnetic energy, so that's how you tell them apart. TDCS is just a current, whereas RTMS is repeated pulses of magnetic energy to stimulate or suppress brain activity. And this can be done on patients who are awake because it's not invasive. It's all on the scalp. So both of those first two, TDCS and RTMS, are on the scalp, but the difference is TDCS is just a constant current, whereas RTMS is repeated pulsations. And then deep brain stimulation is where you actually open up the skull and you implant an electrode into the brain tissue. And that typically goes in what is like the sadness center of your brain. And when you implant those electrodes in there and you stimulate them, it can sort of reset those connections so that you don't experience such negative emotions. But if the question is asking you about which is most effective to treat depression, the answer will always be electroconvulsive therapy. That is the most effective. So you don't have to know much about the other ones, just kind of know the main differences. Psychosurgery. So in psychosurgery, we're trying to remove or destroy brain tissue to try to change behavior in a person. And the most common psychosurgery used to be lobotomy. We no longer do these because they don't work and they only cause bad things to happen. But a lobotomy is a psychosurgical procedure where it was used to calm uncontrollably emotional or violent patients by cutting the nerves between the frontal lobes and essentially the limbic system, the emotion controlling centers of the inner brain. And, it will work to a degree, but you cause more and sometimes even worse symptoms or issues by doing it. So we would only really perform lobotomies in people who had really horrible like violence issues or behavioral issues. And by doing this, it would calm that violence in them. It would calm them down, but it kind of turned them into vegetables a lot of the time. And so it wasn't really worth it. In really, really severe cases where that person was just never going to stop being violent, I guess it's better than letting them hurt others. But for the most part, lobotomies are really not practiced anymore. And especially because there were some really evil like parents and stuff who claim that their children had these issues, and then they would get them lobotomies and their children would be vegetables for the rest of their lives. And so by cutting those nerves, the emotion controlling centers of the inner brain, it calms uncontrollably emotional and violent patients. Lobotomy usually decreased the person's misery or tension, but also produced a permanently lethargic, immature, and uncreative person, because you're cutting brain tissue, and in the frontal lobe, no less, the part that we need most for judgment and planning and maturity and decision making. Okay, last part. So preventative mental health, just like the word says, prevent. We're trying to prevent someone from falling into mental illness. And so it tries to prevent psychological disorders or casualties by identifying and alleviating the conditions that cause them and sort of getting rid of those causes so that we don't see the effect of having a psychological disorder. There's abundant evidence that poverty, meaningless work, constant criticism, unemployment, racism, and sexism undermine people's sense of competence, personal control, and self-esteem. Such stresses increase the risk of depression, alcohol use disorder, and suicide. So if we can get rid of those stresses for people, then we can actually stop depression, alcohol use disorder, and suicidal tendencies from even developing in a lot of people. So to combat this, we try to empower the helpless, alleviate these demoralizing situations. So try to help people out and bring them out of, poverty or unemployment or whatever. Change the environments that breed loneliness. So try to give people social connections. Renew broken family ties. Boost parents and teachers' skills at nurturing children's confidence and their belief in their abilities as well. And community psychologists are actually the most common preventative mental health professionals. Okay. Building resilience. So resilience is the personal strength that helps most people cope with stress and recover from adversity and even trauma. So resilience is essentially your ability to bounce back from something that has really hurt or damaged or upset you. So that's really what we're talking about with resilience. And so that's a focus of preventative mental health, is to actually build resilience in people so that they aren't hit as hard when bad things do happen, because we can't prevent bad things from happening to people, not all of the possible bad things that could or will happen to people. And so instead we try to focus too on giving them the coping mechanisms and the resilience to deal with it when those things do come up inevitably. And then post-traumatic growth. This is kind of a good place to end for, our whole semester of psychology. So post-traumatic growth speaks to actually positive psychological changes as a result of struggling with something extremely challenging or a life crisis. And so post-traumatic growth really speaks to, and I want you to write this down, the term, what doesn't kill you makes you stronger. That's what post-traumatic growth is about. After something traumatic has happened, post means after, right? So after trauma, post-traumatic. After trauma, you grow. You grow from it. You become stronger. You see positive psychological changes. You see greater resilience and strength inside of most people. So, that's it. What doesn't kill you makes you stronger, right? What a nice positive note to end on. So I have so enjoyed getting to work with you guys this semester, even though it's been virtual for about half of it. But I have really enjoyed you guys anyway. And, always feel free to reach out to me about anything. I'm going to have those reviews ready for you in the next few days. And so just make sure to submit the worksheet, take the quiz. Other than that, have a good one.